Staying healthy starts with you, but sometimes you need a partner to keep you on track. Cooper University Healthcare welcomes you to this edition of Healthy You, Understanding and Managing Chronic Pain.
Hello, everyone, and thank you for attending today's webinar, Understanding and Managing Chronic Pain, here on NBC10.com, brought to you by Cooper University Healthcare. My name is Pat Shiraki, and I'll be your host today. Joining me today is Dr. Michael Sabia, the Division Head of Pain Management at Cooper, and also Jessie Dotson, an advanced practice nurse at Cooper. Today, we're going to cover topics relating to pain management. Now, before we begin, we want to review the icons at the bottom of your screen to help you participate today. If you have any questions during the webinar, you can click on the Q&A icon at the bottom and submit your question. We will try to answer these during this webcast, but if a fuller answer is needed, it can be answered later. Additional materials and information are available in the resource list icon that looks like a folder at the bottom of your screen. You can reach out to Cooper to make an appointment by clicking the box to the right of this video player. If you have any technical difficulty, also please click onto the icon displaying a question mark. It covers common technical difficulties that might be coming up for you. An on-demand version of this webcast will also be available early next week and can be accessed using the same audience link that was sent to you earlier. It can also be found on NBC10.com/healthyu. Dr. Sabia, Jessie, welcome to our discussion today. And let's get right to our first question, which I think is one that's really important. Let's help our audience get to know the two of you a little bit better. So, Dr. Sabia, tell us a little bit about what drew you into pain management as a specialty.
Sure. Thanks, Pat. So, choosing a specialty has a good balance of my physical exam skills, learning to utilize different pharmacologic medications that are available in today's current day and age, and using my hands, providing an intervention for patients that can help take them out of pain is probably the most well-rounded, gratifying thing that I love about the field of pain medicine.
Isn't that fabulous? And then, Jessie, with you, you started out actually in nursing strictly, but you also were working with cancer patients at one point, and then you moved into pain management. Tell me about that.
It was, for me, Pat, a natural progression from taking care of oncology patients, and I did a lot of pain management during my care for those patients, and then going back to school, receiving an advanced degree. I wanted to continue that area of helping people easing pain, and so looking into the pain management group at Cooper was a good thing for me.
And so as part of an advanced nursing team, what is it that you do specifically?
Specifically, we spend time in the pain management office making rounds with patients in the hospital. I often do office hours with the patients. I spend some time in the procedures with the physicians when the occasion occurs.
Mm-hmm. So what you're talking about really is that you are a 1-2 punch.
Yes.
Like,
That's right.
Is that true? You really are a team as you treat an individual. Mm-hmm. All right, so let's talk about chronic pain and how you actually identify it. There are, according to statistics, 100 million Americans suffering now with chronic pain. How do you identify that, Dr. Sabia?
The chronic pain has been labeled a disease where it usually starts as an unpleasant sensation in a specific area or region in our body, and if left untreated, it can move forward to affect our mind, our mood, our sleep, and our day-to-day activities. So something that starts as an unpleasant feeling or sensation can really take over our mind and day-to-day movements, because we're not able to live the life that we were designed to from suffering pain.
Mm-hmm. And so when you talk about chronic pain, do you talk about a continuum of pain that lasts a long period of time?
Sure. So depending on what you've read and where you've read it from, most societies categorize being in chronic pain after 3 months, and others 6 months of sustained pain.
Mm-hmm. Right. So, and that can be so troubling for an individual. So typically, what are the areas where you find pain? I mean, I've heard people complain about their heads and their backs. I mean, are there other places too? Where typically does it begin?
Sure. So pain can afflict any area or organ system from head to toe, as you've mentioned. Most common is the spine, specifically the lumbar spine, because we stand on 2 feet and we bend at the hips and hinge forward. So there's a lot of stress and strain that the lumbar spine undergoes, putting it at risk for developing inflammation in that area, arthritic changes as well. Followed by the lumbar spine, the major joints are second most affected, the hips and knees, again from wear and tear, overuse, and injury that has come and gone throughout our lives.
And what about even other places, like, for instance, a carpal tunnel syndrome or something like that? That can be very, very painful.
Absolutely. So some of that may be tailored towards your specific profession or job, how much typing or time you're spending at the computer, but carpal tunnel can lead to severe pain in both hands, numbness in that area as well, and really limit you being able to sign your name, write, or hold objects.
Yeah, and so that really affects then every piece of every day.
Absolutely, Pat.
Okay, so Jesse, let's talk about some of the symptoms of chronic pain. What is it that you find?
I find that the symptoms of chronic pain are related to the specific parts of the body that are causing the pain. For example, if you're having pain generated from the muscles, you might be sore. It may be a mild, dull ache that is constantly going on. If your pain is coming from an organ system, you may feel a gnawing, twisting, excruciating feeling. If it's coming from a spinal problem, you can have pain that radiates down your arms. It can be sharp, it can be shooting. Pain generated from the nerves, it burns, it's electrical, it's extremely uncomfortable.
Yeah, extremely uncomfortable. And then, as Dr. Sabia mentioned a little bit earlier, it really can overtake your life.
Absolutely.
So as a result, the symptoms even can be broader than just the specific pain. Tell us a little bit about that.
So as Dr. Sabia mentioned earlier, chronic pain affects your whole life. So we have a lot of patients that deal with big changes, and they go through depression, they become fatigued. A lot of times they don't get enough sleep because they're just so uncomfortable.
Mm-hmm. And I would think that it becomes so frustrating for them. And so as a result of that frustration, they do develop a sense of depression where they then pull back from life.
Yes.
Have you found that?
Quite frequently. Often we find patients that have these lifestyle changes and they pull back, withdraw. And what we'd like to do is have that person see psychology, because these are devastating things that happen to their lives, and they need someone on the outside to come in and to help them to deal with the mental, emotional parts, the losses that they've had throughout their life due to the pain.
Mm-hmm, right, and so they really do have some losses associated with all of that. Absolutely. And so whether it's a pain that is caused by injury or a systemic problem. And you find, you treat both of those types of things, correct?
That's correct. Sometimes pain can occur spontaneously without any history of trauma or motor vehicle accident, and other times it is directly related to a specific event that occurred causing inflammation or injury in a certain region.
And isn't sometimes pain also can be a signal that there really is something else going on?
Absolutely.
Yeah, I mean, what is it that you have found with that, Jesse?
So you have to listen to your body. If pain is lasting longer than a couple of weeks, you really should start to listen to that and seek some medical attention. So you definitely have to listen to what happens to what your body's telling you.
And as we continue with the webinar today, we're going to look at a lot of these different things that different ways to be able to approach handling pain. So let's talk about some of that, Dr. Sabia. Let's talk about treatment of pain. And I think maybe you mentioned about pharmacology. Let's begin with medicine, because that's the first thing. I have a headache, I go to the cabinet, I get an aspirin, I get a Tylenol. That seems to be like one of the first things. But when pain is severe, sometimes you need bigger help than that.
That's correct. Well, sometimes in the short interim, reaching for a medication to treat the pain is the correct algorithm to start with. And other times, if the pain has been there for weeks or months, sometimes our body becomes tolerant to that medicine, or it's not getting to the root cause of the problem, and an intervention may be needed, a type of injection where we deliver anti-inflammatory medicine and local anesthesia next to the area that's generating the pain. Sometimes therapy, physical therapy, structured by a physiatrist can help tailor certain muscle groups that need to be built up or strengthened that could be causing the pain.
Yeah, so I want to discuss that in more detail, but let's go back just to the medicine for a moment, because there are sometimes people are in such pain that the only solution is a narcotic of some sort, and people are afraid of that, especially today in this day and age when we see potential addiction or ultimately some kind of abuse. But you have a very careful approach to when you prescribe narcotics. Explain what that is and what circumstance would require that.
Sure. So still currently in 2016, narcotics or opioid analgesics have a role in the field of pain medicine. And sometimes it's more short term, but even long term, patients can live a normal life being on these types of medications. Now, most pain practices have a contract or an agreement that's signed by the provider and the patient themselves, which kind of lays down the ground laws that says, we'll be the only practice prescribing for you. Try your very best to use the same pharmacy every time you fill the prescription. New Jersey and other states in the United States have this prescription monitoring program, which is a website that providers sign up for to check to make sure that the patient is not filling prescriptions from different physicians, providers, from anyone else in the state. And then we also do these random urine drug screens to make sure that the patient's metabolizing the medication appropriately. So using a host of those factors helps us be comfortable that the patient's taking the medication, they're using one pharmacy, and every visit we ask them, are you getting pain relief from the medicine?
So really, Jesse, it really becomes management, doesn't it, when there is any kind of medicine that's involved?
Yes, and so just keeping a close eye on the patient, and also just helping them to understand they don't have to feel afraid to take these medications. They have to get over living through the stigma of being on a pain medication. Sometimes they're looked at in a different way, and just bringing them in, letting them know that we have a controlled way to handle the medications, that we're going to monitor them. We're going to try to keep them as safe as possible on the medications. I think it makes it easier for the patients to allow themselves to take the medication and to be more comfortable.
All right, so let's look now at some of the treatment procedures, because you talked about injections, and I've heard even from different family members, you know, well, I have to go back and I have my epidural injection. I mean, that's the way we refer to it, but there's a lot more to it than that. So when is an injection appropriate, and where do you actually inject medicine?
Sure, great question, Pat. So there's a host of different types of injection therapies that are available to help patients, and we really tailor that for each individual after a full history and physical exam, where the pain is located, if it radiates to a certain region in the body, what our physical exam findings show, if the pain gets worse or better when we move the head and neck in a certain direction, interpreting the radiologic testing that was done, an X-ray, an MRI, or a CAT scan. That whole story will fit together with what the radiology test showed, where the pain travels to, and what the physical exam findings are. That helps us choose if an injection therapy would benefit the patient and where to deliver it. Most of the time it's in the spine, the cervical, the neck, the mid-back, and the low back, the lumbar spine, but sometimes it's other peripheral areas in the joints, tendons, different nerves throughout the body, and the arms and legs as well.
And so what are you actually injecting?
A combination of a type of steroid where its principal effect is anti-inflammatory. So an anti-inflammatory medication along with a type of local anesthesia, a numbing medication, or a type of Novocaine.
And so you would do a Novocaine initially before
Correct.
you actually did the injection, so then the pain, you would not have additional pain because of the injection?
That's correct. And usually it's with the guidance of either an X-ray machine or a type of fluoroscope, which is a live X-ray continuous machine, or an ultrasound machine, where we put some local anesthesia over the skin, so when the procedure is all done, the patient won't even realize that the injection was completed because the area should be anesthetized.
Mm-hmm. And so the patient doesn't have to be, again, concerned about additional pain. Is the patient awake through those injections?
Typically, patients are given either conscious sedation, where they're twilight, or they're given a little bit deeper sedation to go through the process. So
they're not wide awake?
No.
Okay.
Cuts down on the anxiety, and they're more comfortable when we give them some sedatives.
I know. Injection in my spine, I would think my first reaction would be, I'm very anxious.
Absolutely.
And I would think that they are a little bit afraid. So do you find that an explanation of it, when they go in, a full explanation of what's going to happen to them, makes a big difference?
Oh, definitely. We always sit down with them and walk them through the steps of the procedure, that they'll be lying on their belly most of the time. We use an X-ray machine. You'll be breathing on your own. There's no breathing tube or the respirator. Sure. The procedure takes roughly 10 to 15 minutes most often, and when they're all done, sometimes they'll notice immediate relief depending on what procedure was done, and other times it may take a few days for them to notice the effects from the delayed response of the anti-inflammatory medicine. So this way they don't have anxiety and wake up in the recovery room and still have that same pain, but no additional pain from the injection. They'll know that it's more of a slow release medicine that we delivered there, that it may take a few days to get the benefits from it.
Okay, so let's talk now about more technology and some advancing technology that you have actually used over the last few years. Radio frequency ablation. Now, oftentimes when I've heard about ablation, I think about cardio issues. And an arrhythmia in the heart, and then an easing of the beat of the heart through this ablation. Explain to everyone what that does and how it applies in the pain area.
Sure. So radiofrequency ablation is under that category of minimally invasive treatments that we can offer patients in pain that don't involve an open surgical procedure. So a common cause of pain throughout the spine could be degeneration or arthritis around certain joints called the facet joints. And these joints can cause pain in the spine or sometimes even radiate out into the periphery. What we normally do is start with a type of injection with the light IV sedation, and with an X-ray machine, we deliver some anti-inflammatory medicine and local anesthesia next to the joints or next to the nerves that provide information to the joint. If that provides short-term pain relief for a couple days or so, instead of doing the injection again and again, we'd bring the patient back, provide the same sedation, put a very similar needle next to the nerve. Once it's in the correct area, instead of injecting it with medication, we would heat the tip of the needle up for about 90 seconds. And that actually turns off the circuitry of the nerve through this RF energy or radio frequency heat energy generated by a thermal generator.
I mean, does somebody feel a burning sensation?
They don't, no. They're sedated, and we put a little local anesthesia right into that needle. So before the ablation takes place, the area will be anesthetized, and it's something that is done as an outpatient, and the patient's in and out of the facility within a few hours.
I mean, that really is pretty amazing. What do you find, Jesse, with the patients who you then follow up who have had the ablation?
They're quite happy about the ablation. They come in and they had this nagging back pain and have had it for some time, and to go through the process of going through the diagnostic or the procedures to diagnose the pain, and then to go through the radio frequency, come back into the office and tell me that now they're able to get up and do things and spend time with family, play with kids, do all the things that they had been doing in the past. So they're pretty pleased with it. If they respond to that diagnostic procedure, that test, it's a good percentage of the patients that are going to do extremely well with the radio frequency.
And how long then does that last? Is that a longer term solution, Doc?
On the average, for about a year. Some patients get 9 months of relief, others several years, but the average is about 1 year duration, because all nerves in our body do regenerate. Sometimes when the nerves regenerate, the same pain returns. Other times the nerve grows back after 9, 12, or 15 months, but the pain doesn't come back. So not all the time the pain will return. If the pain comes back and we're sure it's that same pain, this same procedure can safely be repeated.
And so I find this interesting with elderly people. Many of them have what is termed a spinal stenosis. And so they don't have as much movement. They have, and oftentimes, a lot of pain. Do Do these kinds of treatments help in that situation too?
They do. So spinal stenosis specifically is a narrowing of the spinal canal where the majority of our nerves originate from. And that may be due to arthritis that has built up inside the spinal canal. Other patients are born with congenitally a smaller spinal canal. And because they're limited in the way they're able to move day to day, they develop restrictions or inflammation around these joints. So an ablation is an option for them, as well as different types of nerve blocks, different types of injections that are done similarly with the X-ray or ultrasound machine, and we're delivering to a specific region in the spine, again, that anti-inflammatory medicine and local anesthetic to stop those nerves from firing signals over and over throughout the spinal column.
So let's talk about another procedure. This is called spinal cord stimulation. That sounds fascinating to me. I had no idea what that was about. Explain it.
Sure. So this is a technology that's been FDA approved for decades now, otherwise known as dorsal column stimulation, and it's approved for therapies for patients who have pain throughout the spinal column that can radiate to the extremities, pain that's limited to just the extremities in this complex regional pain syndrome or RSD type syndrome, and also patients who have already undergone back surgery and they still have the same pain than what they started with, and they're in this post-laminectomy syndrome. So in those patients, instead of doing further operations, we would bring the patient in, provide the same sedation similar to what patients receive for a colonoscopy, and we do an epidural like we would normally do for a steroid injection. Once the needle's in the correct area, instead of delivering medication through the needle, we would thread a thin electrode through the needle. That electrode sits next to certain nerves in the spine that are generating the pain, and it emits an electrical impulse. So when the spinal nerve sends signals up to the brain, the electrode interrupts those pain signals. So there's no medications released. It's just an electrical energy that helps reroute those pain signals from getting to the brain.
I mean, that's pretty fascinating. Jesse, I'm watching you. You're nodding your head. I'm sure you've seen patients who have also had success with that.
Absolutely. If patients have a successful trial, because when we do the stimulator, we don't automatically have the device implanted. So we do a trial of 5 to 7 days. If they respond successfully to the trial, then they are extremely happy with the actual implant of the device, and then can go on to live quality life.
Okay, let's talk about physical therapy, because that really is an important component. How do you lead people through that, Jesse? How important is that?
Physical therapy, chronic pain is managed with from a multimodal aspect. We use the oral medications we talked about, the injections we've discussed, lifestyle changes, and then adding that physical therapy in, getting the person moving, again, strengthening their core, loosening their joints. This is all part of either reducing or preventing that chronic syndrome from happening.
Yeah. And so how do you keep pain from coming back?
Sure, so that definitely involves some type of pain change, Pat, where if we alleviate the pain and clear out the inflammation, but the patients continue to do their same routine, it's almost inevitable that the pain will return. That change may involve your diet, moving, adding some movement, avoiding certain movements. So we know for sure certain foods that we eat promote inflammation. Simple sugars, starches, artificial sweeteners, processed foods, and other foods have a natural anti-inflammatory effect, like salmon, walnuts, berries, avocados. So we try and incorporate and recommend certain changes in the patient's diet. And then again, watching the way they're moving from day to day. A lot of the stretching exercises that they've learned during physical therapy, we encourage that to continue as an outpatient. Do a 10 or 15-minute stretch routine after a hot shower. Make sure you incorporate a walk. Maybe it's 5 or 10 minutes just to get the blood flowing. But if you just wake up and go to work every day and sit for 5, 6, 7 hours, a lot of the muscles will get short, the inflammation can come back, and it's almost inevitable that the pain will return.
Yeah, so you really do, though you may be pain-free, you do need to be conscious about what it is that you eat, how you move, what it is that you do, how you take your meds, and all of that.
Absolutely.
You can't just kind of do it automatically.
No.
Right? You have to be really conscious.
Absolutely. That's going to play out to your future on keeping a healthy body, a healthy spine, and a natural anti-inflammatory state in our system.
Sure. So tell me this. We know we have some weekend warriors who go out and they really feel pretty well, but then they decide that they're going to train for a big marathon, and they decide that they need to run all 20 miles in one day, and they have not trained to really get up to that point. How do you know that the pain that you're experiencing after that is just, maybe some stress on your body because you overdid it, or whether you really injured yourself?
Sure.
How do you know?
So that could be a challenge, because pain intensity, how severe the pain is, won't really make us lean one way versus the other. If it's just normal post-op soreness versus a true organic injury, it's more of duration, as Jesse mentioned before. Pain that persists beyond 2 weeks is not in that normal post-workout soreness. Pain that radiates to a certain part of our body, if it starts in your shoulder and then radiates to the hand, starts in your hip and travels down your leg, an area that has numbness, tingling type sensation, that's not normal post-workout soreness as well. So pain that persists for a few weeks, is radiating, is associated with numbness and tingling, are things that we're concerned that there may be some type of injury in a tendon, ligament, muscle, or other structure.
And so give us an overview about how the pain management program and treatment program works at Cooper.
We really take that team approach with different physicians, nurse practitioners, therapists, psychiatrists. We really work in harmony as a team to help approach the patient with the appropriate diagnostic testing, the workup, and the current treatment modalities that are out there in today's day and age.
Well, we were eager to hear from one of your patients, Dr. Sabia, and so we asked one of your patients to share her experience. We want you all to take a listen to that.
I was experiencing horrible lower back pain. I couldn't sleep through the night. If I just moved a little bit, it was just awful. I couldn't reach down and tie my shoe. It had just gotten progressively worse. My family doctor had recommended Cooper's Pain Management Center, so I made an appointment, and that's when I met Dr. Sabia. When I first met him, he gave me a thorough examination. He sat me down. He explained to me what he thought was wrong with my back. He explained it in terms that you don't need an advanced medical degree to understand what he's saying. After he evaluated me and told me what he thought my issue was, we had to go through the protocols of the insurance company, but he had given me, I think it's a radio frequency ablation, and he explained to me basically what this entailed was he would be burning the nerve. It wasn't scary at all. Dr. Sabia talked to me and explained exactly what the procedure entailed. I was like semi-awake when they did this. You're not like out with anesthesia. And after the procedure, it was just wonderful. I can't explain it to you if you have never had chronic back pain. Just what a great feeling it is to get up, to be able to reach down and tie your shoes, to go walking, to work out. It's just been great. Life after seeing Dr. Sabia is just so much better. The chronic pain is gone. I can bend down, I can reach my shoes. I mean, it's just, it's so much better, so much better.
Well, you certainly can see on Mary's face that she really does feel 1,000% better. And so was it a long process for her, Jesse, as you did the follow-up with her?
We have two nurse practitioners with the group, and actually I did not follow Mary, so I'm sure she kind of went through the same process that patients go through as far as having the diagnostic and then having the radio frequency. So it was exciting for me to watch this clip about Mary as well. I haven't.
Not so unusual.
No, not at all.
To
not
see
at
your
all.
patients. It must make you feel great too, Doc.
Very gratifying, really. It makes us so excited to come to work every day knowing that we can have an impact like this on someone's life.
Okay, and again, a whole team approach.
Absolutely.
So we also have some questions from viewers, and we'd like to go through a few of those. And this is one. This person asks, how do I ease pain in my lower back from a degenerative disc and neck?
Sure. So the spinal discs act as the cushion in between the vertebrae or the spinal bones. And the majority, more than 2/3 of the spinal disc, is made up of water. So as we get older, the water content runs a little low, and there's degeneration where the spinal bones have a closer proximity. That may allow the bones to rub back and forth, which causes inflammation to pool and collect in and around the spinal column. In those patients, an inversion table can help offload the pressure on the spine. Physical therapy can definitely help strengthen some of the ligaments and tendons and muscles in the back to help benefit their posture. Sometimes an injection therapy is indicated in these cases when the inflammation has really built to a high amount and the pain is severe. An epidural steroid injection done under the X-ray machine with some light sedation can provide some short-term relief.
And so there are a lot of different options.
Yes.
Okay, that really need the evaluation. Here's another question. This person says, I have chronic neuropathic pain in my feet. What can you offer in the way of hope of not using opioid drugs to treat it? What do you think?
So neuropathic pain most of the time in the feet originates from diabetes, diabetic neuropathy, followed by cancer, chemotherapy treatments, chemotherapy-induced neuropathy, and that can cause terrible burning, tingling sensation either in the hands or the feet. And we're fortunate that there's other options out there besides opioids or narcotics, one specifically being a topical compound cream where the provider designs 3, 4, 5 different medications that are available by mouth but compounded into a cream that's placed just locally on the site of injury. A medication that can help with inflammation, muscle spasms, nerve pain, and it's only absorbed locally at the site, so there's much less of a chance that there'll be any side effects of sleepiness, dizziness, feeling unsteady, as if you took the medications by mouth.
I mean, I find that fascinating. So even for a neuropathy that might have been triggered by diabetes or by cancer treatment.
Mm-hmm. That's correct, yep. So we used to reach for the prescription pad and prescribe something by mouth, and sometimes we do, but it's hard to get that type of pain under control with 1 or even 2 medications. So when we start adding different medications by mouth, they work together, but then the side effects can really limit the response that we're hoping for.
Oh, all right, so here we have our third question. This is an interesting one because this is about shingles. Mm-hmm. This person says, I had shingles 9 months ago and I'm still experiencing pain at the site where they erupted. What treatments are available for this pain?
So once the rash has healed, about 20% of patients who suffer shingles are in this chronic pain category called post-herpetic neuralgia. And that's also a type of burning neuropathic pain. And there are a host of options that are available, with the most common site being over the rib cage, the flank region, or the thoracic spine. Different nerve blocks can be done between the spinal ribs, an intercostal nerve block, different field blocks or injections over the area where we deliver, again, anti-inflammatory medication and local anesthetics to try and stop those nerves from spontaneously discharging pain signals.
And so even though the shingles have cleared,
They still have residual pain, yeah, and it's unfortunate. And I'd just like to mention for patients who are not quite ready for an injection, there are also topical creams that they could use in these areas. There's also certain patches that add a little bit of capsaicin, the hot pepper, that can desensitize the area. So there are some non-invasive treatments as well that might be helpful before they get to the injection.
Okay, and does it ever clear up?
It does resolve. It can resolve. Sometimes it seems like it's not going to go anywhere. It lasts for 6 months to a year. It can clear up, and there are a small population of people where they have to manage it.
Okay. All right. So again, solutions are available though by asking the questions. This person says, I sit about 10 hours a day at a computer. I try and get up and move around, but just don't have the time. At the end of the day, it's very difficult to move. I'm very stiff. What suggestions do you make for that? Jesse, what do you think? So somebody's sitting at a computer for a long time and they're just stiff and they feel like they can't get up. What do you suggest for them?
I would hope that at their job they would have some time where they can take a 5-minute, 10-minute break to get up, to walk around. They might want to look at the type of chair that they're sitting in, the height of the desk, whether they're spending a lot of time looking up, or what position their arms are in. So just a lot of mechanical things, adjustments that they might be able to make their day more comfortable.
I would think stretching too would make
Absolutely.
a big difference. Yeah.
Yep. Just getting up every 30 minutes, stretching your legs. Even if you don't have a dedicated 5 or 10-minute break, you can stand up to help lengthen the muscles there, where when we're in the same position hour after hour, those muscles get shorter, stiffer, tighter, and that in itself can cause pain.
And one final question, are there any other treatments being developed that are not currently being used for chronic pain?
So thankfully, there's a lot of things, Pat, in the pipeline that are in the research phase. Just to name a few, are improved technology and programming for that spinal cord stimulation or the dorsal column stimulator to help capture different types of pain syndromes. Different uses for ketamine, which is an anesthetic that's used in the operating room that we realize has a lot of analgesic or pain properties in depression, post-traumatic stress disorder, that syndrome we mentioned earlier called complex regional pain syndrome, and then other novel drug therapies that are in phase 2 or phase 3 trials, which just means they're years away, but at least there's research being done with the hope in the next couple years that there'll be more novel therapies readily available to the public.
Well, hopefully there'll be more opportunities for more people to be pain-free because of the great work that you do. Thank you. Thank you both so much.
Our pleasure.
Thank you for having us.
We certainly do want to thank our guests today. If you missed anything in our webinar or you want to rewatch any part of this video will be archived on NBC10.com/healthyu. You can also click now on the box to the right of this video player and make an appointment today. We'd love to hear your thoughts also about today's webinar. Please click onto the survey button and complete a short questionnaire. Remember to check back on NBC10.com/healthyu for future information and future webinars. I'm Pat Shiraki. Thanks for joining us.